Hello everyone, myself Dr. Deepal Prajapati, Assistant Professor of UN Mehta Institute of Cardiology and Research Center. I am going to take a lecture on pathophysiology of pulmonary hypertension in congenital heart diseases. Here we are going to review the fetal circulation, simple intracardiac shunts and causes of pulmonary overcirculation. Then we are going to define and categorize pulmonary hypertension and describe the congenital heart disease induced pulmonary hypertension. Now, fetal and transitional circulation. This is the slide showing fetal circulation, where you can see the umbilical vein carrying the oxygenated blood going to liver via ductus venosus, bypassing the liver, entering the IVC, going to RA, and thereafter in fetal heart. The course of oxygenated blood through umbilical vein, it bypasses the liver via ductus venosus, mixes with IVC, it goes to the Eustachian valve, shunts towards the PFO, from there to LA, from LA to LV, and from there to aortic valve, and from there to the arteries of head and neck. Therefore, the oxygenated blood from the umbilical vein perfuses the brain and coronary arteries by shunting across the liver via ductus venosus and shunting across the right heart via foramen ovale. See here, the blood coming from umbilical vein through ductus venosus, it enters the heart via IVC, from there to Eustachian valve, from there to RA, PFO, from there to LA, from LA to LV, through aorta, and it goes to the upper part of brain and upper extremities of fetal circulation. Now, desaturated blood from SVC from brain, it takes a different course. It comes from SVC to right atria, from there to tricuspid valve and not to PFO, from there to pulmonary valve, through ductus arteriosus, and from there to descending aorta and back to the placenta for the oxygenation. See the diagram here. The blood coming from the fetal brain comes from SVC to RA, from there to RV through tricuspid valve, and from there to pulmonary artery through pulmonary valve, and from there to descending thoracic aorta from the patent ductus arteriosus. Now, the transitional circulation. What happens to the foramen ovale? Here, the transitional circulation begins when the umbilical cord is clamped at the time of birth and lungs are inflated. The cord clamping removes the low resistance placenta from the circulation and raises the systemic vascular resistance. Lung inflation and increase in partial pressure of oxygen lowers the pulmonary vascular resistance dramatically, thereby causing increased pulmonary blood flow and increased blood return to the left atrium, which causes increase in left atrial pressure than the pressure of right atria, which functionally closes the flap of the tissue covering the patent foramen ovale. Now, functional closure occurs quickly at the time of birth, but the anatomical closure usually requires weeks. A PFO, that is pro-patent persistent in approximately 25% of adults. Now, what happens to PDA? The ductus arteriosus remains patent in utero due to hypoxia, mild acidosis, and placental prostaglandins. Removal of these factors after delivery causes functional closure, with anatomic closure occurring few weeks later. The persistent patent ductus arteriosus often occurs in premature infants with lung diseases. Indomethacin, via its antiprostaglandin actions, can be used to try and close a PDA. Before anatomic closure of the PDA and PFO, the pressure of the right atrium increase from the left atria causes reversal of the fetal circulation, that is right to left shunting, and thereby causing cyanosis. What are the other factors adding to this? These are the hypothermia, hypercarbia, acidosis, hypoxia, and sepsis. These all can cause a reversal to the fetal circulation, that is right to left shunting, and thereby causing cyanosis. Now, pulmonary arterial hypertension. Pulmonary arterial hypertension, by definition, pressure of mean pulmonary arterial pressure more than 25 mm of mercury at rest, with provided that left atrial pressure is less than 15 mm of mercury and pulmonary vascular resistance of less than 3 Woods unit, is considered pulmonary arterial hypertension. The normal mean pulmonary arterial pressure is around 15 mm of mercury, independent of age, gender and ethnicity. Now, this is the classification for adult and pediatric, which is having 5 categories here. The pulmonary arterial hypertension, the second category persistent pulmonary hypertension of newborn, third category is pulmonary hypertension due to lung diseases or hypoxia, fourth category chronic thrombotic pulmonary hypertension, and fifth category is miscellaneous causes. Now, in young children, persistent pulmonary hypertension of the newborn and congenital heart diseases are the primary causes of pulmonary arterial hypertension. More than 80% of cases are included in this. The idiopathic PAH, although less common, is also an important cause in children. Now, why does PAH occurs in children? It occurs usually due to 3 main things: increase in left atrial pressure, increase in pulmonary blood flow, or increase in pulmonary vascular resistance. Now, why left atrial pressure increases? There are few causes. Either there is left ventricular systolic or diastolic dysfunction, mitral valve or aortic valve stenosis or regurgitation, or pulmonary venous obstruction. Now, increased pulmonary blood flow due to second causes is increased pulmonary blood flow may be due to congenital heart disease with left to right shunt, and the third one, increased pulmonary vascular resistance due to pulmonary parenchymal diseases or thromboembolic disease. Now, PAH associated with congenital heart disease, it is the major acquired complication of congenital heart disease with left to right shunt. It causes increased morbidity and mortality. It may prevent complete repair in congenital heart disease with advanced pulmonary vascular disease. At least 15 to 30% of congenital heart disease population is thought to develop at least transient PAH. As we see here in this slide, there are histopathological changes which occur in pulmonary arterial hypertension. Now, left to right shunt, it causes increased pulmonary blood flow which leads to pulmonary vascular injury and shear stress, then which leads to progressive smooth muscle hypertrophy and hyperplasia and intimal proliferation and pulmonary vasoconstriction as shown in the slide. The risk factors for PAH in children with congenital heart diseases according to the type of defect, according to pressure and flow of the left to right shunt, and also in some non-cardiac syndromes, especially Down syndrome, where there are increased risk of pulmonary arterial hypertension. By according to now type of defect, the truncus arteriosus AV canal TGA with VSD carries almost 100% risk of pulmonary arterial hypertension if untreated. VSD and PDA carries moderate risk, where VSD, here risk of Eisenmenger syndrome if untreated is 3% when the size of defect is less than 1.5 centimeter and 50% when the defect is 1.5 centimeter more than it, and the lower risk is associated with ASD and PAPVR. When does congenital heart disease with pulmonary hypertension develops? Now, the age at which congenital heart disease cause irreversible pulmonary vascular disease varies. Endothelial changes can occur as early as 2 months after birth in some children with increased pulmonary blood flow. The type of congenital heart disease matters. Combination of high pressures and low pressure flow causes more rapid and severe remodeling. The clinical onset ranges from as early as 4 to 6 months in CAVC or truncus arteriosus to never in small ASDs or VSDs. The pulmonary vascular remodeling process is reversible in early stages of these diseases. Now, Eisenmenger syndrome. What is it? It is the most severe form of congenital heart disease associated with pulmonary arterial hypertension. The definition: it is congenital heart disease with an initial large systemic to pulmonary shunt that induces progressive pulmonary vascular disease and pulmonary arterial hypertension with resultant reversal of the shunt and central cyanosis. When shunt reversal occurs, symptoms include cyanosis, dyspnea, fatigue, dizziness, syncope, and arrhythmia. It also causes poor exercise tolerance. Life expectancy with Eisenmenger syndrome is markedly reduced. So, here we can say now the congenital heart disease is a frequent and important cause of pulmonary arterial hypertension in children. Early repair of congenital cardiac lesions with intensive post-operative care is the best strategy to prevent the development of progressive PAH in congenital heart disease. Once PAH develops, aggressive medical treatment ensures the hopes of reversibility. Chronic pulmonary arterial hypertension increases the morbidity, mortality, and anesthetic management must be carefully considered. Thank you.